This is the third installment of the Level 4 Test 1 workshop on CVADs. So I'm going to basically just be going over the technical side of things and mentioning some nursing management along the way. Make sure you read the appropriate pages according to your modules. So let's start with central venous access devices. So the definition of what this is, these are catheters placed in large blood vessels such as the subclavian vein or the jugular vein of people who need frequent or special access to the vascular system. It's very invasive. There are different types. So we could have centrally inserted catheters, which we'll talk about. Or peripherally inserted central catheters, which is a PICC line. And then also implanted ports. So we're going to discuss those ones, as well as the midline catheter, which is not technically a central catheter. In terms of the advantages and indications, table 16.19 gives you a list, so make sure you find that in the book that discusses the indications, common indications for central venous access devices. So make sure you look that up and look at that table and pay attention to that. One advantage is that you get immediate access to the vascular system, to the central vascular system or venous system. There's a reduced need for multiple venipunctures, which is significant in patients who have chronic diseases like, a chronic cancer. There's a decreased risk for extravasation injury. So, for example, if someone was receiving chemotherapy and they were receiving it through just a regular IV, like a peripheral IV that you put, in the arm, if that extravasates, chemotherapeutic drugs are very destructive when it comes to tissues. There's a decreased risk of that when you have a larger catheter going into a larger vessel, which will always be a vein when we're talking about these central venous access devices. Also, an advantage would be frequent, continuous, rapid, or intermittent administration of fluids or medications. One advantage as well is that we can infuse vesicants, which are, again, agents that can cause tissue damage, blood and blood products, and parenteral nutrition with less of the side effects of having a smaller IV. So we have the ability to infuse vesicants, blood products. So I'll just write blood products, and this is all from your textbook, and parenteral nutrition, which is that second part of the workshop that we did. Another huge advantage, especially in the ICU, is it provides a means to perform hemodynamic monitoring, which you'll learn a lot about in test 3 and test 2. So there's something called a Swan-Ganz catheter that's a central line that can tell you a more accurate blood pressure than what we get when we use that sphygmomanometer that I can't pronounce, obviously. And you can also obtain venous blood samples. Now, keep in mind, if you have a patient with a central line on your floor, like working in the hospital, the phlebotomy is not permitted to draw blood from a PICC line because that's under an RN scope of practice, so you'll have to draw those samples. It is indicated also to insert a central line or a PICC with patients who have limited venous access, like peripherally. So that would be, maybe someone who has an addiction to intravenous drug. After a while, after using it, you kind of blow veins throughout the arms, the legs. Sometimes you've seen in movies maybe where they inject between the toes. And that scar tissue makes it almost impossible to access that vein. So they would have limited peripheral vascular access. That could be true of patients with cancer as well, who are constantly being stuck, or any other type of disease that requires transfusions, like thalassemia, where they require multiple blood transfusions frequently. This also central lines may also be used to inject radio-opaque contrast media, and that's going to be a dedicated line that you're not supposed to use for anything else. So they need to be labeled, and they usually are. They kind of come in different colors. If you start to work in the hospital and you're working with these lines, you typically get training on each different type that you're going to be using. Let me just try to write while I'm not talking. Contrast media. Or at least say what I'm writing. So those are some indications as to why someone would get a central venous access device. A big part of that is that they are receiving long-term therapy. That's a huge part, because we don't want to keep sticking them with IVs every time they come to the hospital. Or keep blowing IVs while they're in the hospital. So these PICC lines and central lines can be a lot more beneficial when it comes to patients who have a long-term or chronic illness that requires multiple transfusions and medication administration with multiple medications. So let's talk about centrally inserted catheters. Keep doing that. Catheters. So central venous catheters. Is a term. So CVCs. So we'll refer to these ones I'm about to describe. These are catheters whose tips rest just above the right atrium. It's in the distal end, not quite in the heart, but in the distal end of the superior vena cava, near its junction with the right atrium. So if I'm drawing that rudimentary heart, I tend to draw a lot. Superior vena cava is up here. The catheter is going to go up and rest just right above this right atrium. This is right atrium, right ventricle, left atrium, left ventricle. So it's very, very invasive. And so we need to be vigilant as nurses to make sure that it's correctly placed. With central catheters, it's necessary to get a chest x-ray to ensure that it's placed properly. When we get to PICC lines, I'll talk about something really cool that Baycare does, but I'll wait until then. A little teaser to keep you listening. The other end of the catheter exits through a separate incision on the chest or the abdominal wall with these central catheters. So they come out from that vessel to be attached to other lines. There are non-tunneled catheters. That are placed in the subclavian or internal jugular vein, more rarely in the femoral vein. These are best for patients with short-term needs, in an acute setting. So these non-tunneled catheters, and when I talk about tunneled, it'll kind of make sense, but I had mentioned up here that it's usually in the subclavian or internal jugular. You might have an IJ line that you're dealing with that goes right into the neck, basically. Think in your mind like why you might not want to put a line in the femoral vein. It's near the femur, so it's near the groin, right? And so it's much more difficult to keep clean and sterile because when we're doing these dressing changes for central lines, it needs to be with aseptic technique. So if you have a patient who is incontinent and has this central line going through their femoral vein, there's a higher risk of infection for that. So keep that in mind as well. In comparison, there are surgically placed tunneled catheters. The types that the book mentions are your Hickman, Broviac, and Groshong. These are suitable for long-term needs. And the key is that the catheter is tunneled, and there are images in the book, through subcutaneous tissue in the chest, and a synthetic cuff called a Dacron cuff anchors the catheter within the subcutaneous tissue. So I don't really have time to draw like a perfect human being torso, but we've got the heart over here, it's a beautiful heart, isn't it? So the superior vena cava, let's say that it's coming up through the chest under the subcutaneous tissue, and then it's going to go into the superior vena cava. I tried to draw that anatomically left. So it's going to be tunneled from over here underneath the skin with this Dacron cuff, and that Dacron cuff not only anchors it in place, but helps prevent migration of bacteria. So it decreases infection risk. So you want to know what type of line you're working with. It does not require a dressing after the site heals. So once the site where it was inserted is healed, it'll scar over and you won't need to put a dressing on it. For these types of catheters, the number of lumens varies. It may be single, double, or triple lumen. Multi-lumen catheters have a variety of advantages. They're useful for critically ill patients. So single lumen, double lumen, or triple lumen. And as I said before, some of them may be used for CT, so you're not going to be able to use that to infuse fluids or anything like that. With the multi-lumen catheters, sometimes you'll get those central lines that clearly state what each lumen is for in tiny print. Otherwise, you would have to label them. Incompatible drugs with multi-lumen catheters can infuse in separate lumens without mixing, while the third lumen gives access for blood sampling. So let's say my weird-looking patient, I'm going to make him disappear with my little lasso tool. So if we have, let's say this is the superior vena cava, and I have my central line going in so that I have a little branch off of one lumen, a branch off of another, and then a branch off the third, basically. What'll happen is this drug's infused here, so it doesn't interact with this drug over here, and then this third lumen could maybe be used to sample blood. And remember when we talked about TPN, you really don't want to sample blood from, if you're infusing TPN from that line, because it's going to make their blood sugar look like they should be in DKA or something. Let's see. Let's talk about PICC lines. So peripherally inserted, central catheters. For those of you who already work in the hospital, you've probably seen all of these, especially if you work on an oncology floor, but any floor really. You'll see a lot of ports, which we'll talk about on an oncology floor. Vein selection for PICC lines. The basilic is the most favorable, and I'll keep reminding you of that because it has a large diameter. So there's less risk of any irritation to the vein, and you can infuse things that are more vesicant. Other options are the cephalic vein, the median cubital, or the brachial. So there are options for the different types of veins. Lumens, again, they may be single, multiple, single, double, triple. And this is where you really want to pay attention to the compatibility of your drugs. You always want to be aware of that, especially infusing things IV, because some drugs are incompatible with certain fluids. Like certain drugs are incompatible with D5W. There are very, very few drugs that are incompatible with normal saline, and they're very strange drugs. But double lumens for PICCs are preferred because they allow for simultaneous use. So if you have to infuse fluids in one and something else in another, like a Cartesian drip or something like that. Length of usage. It's typically for patients who need vascular access for 1 week to 6 months. So like I said, because this is so invasive, you're not going to want to, have a patient who comes in like hungover and into the ER and they just had like a crazy night of partying. A peripheral IV and infusing just like a bag of fluid would maybe be fine for that. But if we have a patient who has some sort of chronic illness, a PICC line would be preferable because we do know those peripheral IVs tend to kink and they're in smaller veins, and if they're critically ill, they're probably receiving vesicating drugs. So the more invasive, it's associated with more long-term benefits, but they may be in place for longer periods. The advantages of using a PICC line over a central line is that there is a lower infection rate with PICC lines. There are fewer insertion-related complications, which we'll kind of go over toward the end of this. Of course, decrease cost. It's less invasive. And this is what I wanted to tell you about earlier. There's the ability to insert the PICC line at the bedside. And at Baycare, it's really cool, or in an outpatient area. I mentioned the chest x-ray is necessary to make sure that it's in the right place, like right above the right atrium. Well, when I was in my residency, I was able to observe a nurse who is specially trained to insert PICC lines, doing so for a patient. And it is a sterile technique, and instead of using a chest x-ray, what they would do is have a electro sensor at the end of the PICC line, so that when they inserted it right into the superior vena cava, they could move up and down to see where it was placed, and that electrosensor would show the EKG on the screen, and it would show based on the P wave where the tip of the catheter was resting. So electrically, they could tell that it was in the correct spot. So that's just a really cool development I thought you guys should know about that you might be able to see in the hospital. But you definitely need a chest x-ray to ensure proper placement. And facilities vary based on their protocols. You'll read that 1,000 times in your textbook, which you should always be doing. Some risks with PICC lines. Make sure you look at table 16-20 for complications. There is an increased risk for DVT and also for phlebitis, which is inflammation of that vein. So if you see any redness, any purulent drainage, that would be infection. The vein would look hard and cord-like. So on table 16-20, depending on your edition, make sure you use your index or your table of contents to look through that reading to find complications of central venous access devices in general. So we'll go over that toward the end. But specifically with PICCs, there is an increased risk of DVT and phlebitis. As nurses, I think it cut me off for a second. In terms of precautions as a nurse, you've probably seen this in clinicals or if you work with patients who have PICC lines or mastectomies. You do not use the arm with the PICC to take a blood pressure or to draw blood. So the reason you can't use that blood pressure cuff on that PICC line is because it increases the risk of vein damage and thrombosis, because it's basically compressing that vein so that it's squishing it up against the catheter. And that's a foreign object, so that's going to cause an inflammatory process, which stimulates the coagulation cascade. So for precautions, no BP or blood draws. I'm not talking about taking blood from the PICC. I'm talking about, how the phlebotomists come in and needle stick on that arm. You should not be doing a separate needle stick on the PICC line arm. And if you have questions about that, feel free to contact me or clarify with your instructor. The other thing that's really important with PICC lines and central lines is because it's basically you can only really use a 10 cc syringe or larger to flush the line, because a 5 cc syringe has too much pressure in it and can cause the PICC to have complications. So you only use a 10 cc line to flush a PICC line, and you use that push-pause method. So that's really, really important with PICC and central lines. Let's talk about ports. Implanted infusion ports are surgically implanted central venous catheters connected to a reservoir or port whose tip lies in the desired vein. You may have seen this on the oncology floor. The reservoir you can see in the textbook on your chapter where it covers CVADs or central venous access devices. You can see that it's being accessed with a specialized needle called a Huber needle, and that's so that the silicone in the reservoir does not core and cause complications in terms of administering medication through there. Materials that make up a port may be a titanium or plastic reservoir. Covered with self-sealing silicone. It requires the use of a special non-coring needle so that it doesn't core out that silicone. And that has a deflected tip. This prevents damage to the septum that could make the port useless. So I'll do my best to kind of like redraw what this reservoir looks like. So here we have like the patient's chest, and we're looking at it kind of in a transverse direction. And we got this subcutaneous tissue underneath. So it's kind of like this reservoir here, where this part may be made of titanium or plastic. And there's this silicone right here, this blue block that I'm drawing. This part that I'm going to kind of highlight in the yellow is where the medication or fluids go. It's like a light yellow, if you can see that. And that actually has a passageway into the catheter, which I'll draw in purple, that inserts into the vein, which I'll draw in blue. And so this is used for patients who require long-term therapy. This is embedded within that subcutaneous tissue, and it's usually found in like the upper corner of the chest on patients. So if that didn't do it for you, that picture's in the book. Let's see. Usually to access a port, you need to be checked off on that. Back in the day, you used to have a certification, but it is a sterile procedure to access a port, obviously, because it's going into the vascular system, and you don't want to pass any bacteria into that area. So what'll happen is the drugs are placed into this reservoir right in here. And then through direct injection, that Huber needle is kind of like deflected at the end so that it doesn't core through the silicone. And then it'll go into that IV line and fill up the vascular space. The drug will be released slowly from the reservoir into the bloodstream, and you can see like this is larger than the port, so that's kind of why it's like can't fit all of that there at once, so it kind of like does it over time. And it'll be attached to a pump as well, unless it's being directly injected in. So like you could directly inject drugs via syringe into the port with a Huber needle, or you can attach it to like an IV pump, and that will just kind of like wait in the reservoir until it's turned to kind of get into the bloodstream. Some benefits of these ports is that they're used for long-term therapy, like the longest of terms. There's a lower risk of infection because most of the time they're not accessed, so this tissue over top of it is healed or at least covered with dressing until it heals. There are also cosmetic advantages because it's a lot less noticeable than having a PICC line. and then there is less maintenance when it comes to ports. I mentioned midline catheters. I'm just going to go through those real quick. They're technically peripheral catheters because they don't enter a central vein. The use and care is similar to a PICC line. It may be inserted by a specially trained nurse. They're usually about 3 to 8 inches long. And I know I'm rattling off pretty quickly, but this is all in your book, so I'm just trying to highlight the main points. They may be single or double lumen. Usually it's an antecubital insertion into either the basilic or cephalic vein under ultrasound guidance, kind of like how they insert with PICC lines. I told you they have that. These ones don't necessarily have that tip, but they have the electro tip, but they have ultrasound to guide to find the correct vein that they want to be in. And then the tip rests right below the axilla, so just below the shoulder joint. And it's just below the shoulder joint because if you think about it, those midlines, we're talking about midlines now. If this shoulder joint is moving a lot, you don't want it to like get displaced or anything like that. That's supposed to be shoulder. And then here's your little dorso here. These midlines may stay up to 4 weeks in place, 4 weeks or less. Complications of all of these central lines, and technically midlines are peripheral, but still invasive. Go to that table 16.20. That's in the 11th edition. If you can't find it, make sure you use your index. Big ones to remember are catheter migration. So possible cause could be that there was an improper suture placed for the central line. There may have been some sort of insertion site trauma, changes in intrathoracic pressure, like if the patient coughed right as they were inserting it. Forceful catheter flushing, and that's why it's important that you use that push-pause method with PICC lines, because if that 5cc syringe has that much pressure in it, it's a smaller space, it can cause migration of the catheter. And then catheter migration could also be spontaneous, where it just kind of like moves out. It can even kind of like move up the jugular and into your brain. Manifestations, make sure you know those. They would experience sluggish infusion or aspiration. The patient would experience edema of the chest or neck during the infusion. When the infusion's going, the patient might say, "Oh, I hear some gurgling in my ear." Dysrhythmias, if it's too far down into the heart and irritating that endocardium. One big thing about central lines and PICC lines is you need to know where like the catheter insertion site is, and it needs to be marked, because if it dislodges and moves outward or inward, then let's say you put a piece of tape there to mark exactly where it was. Well, now it looks like the catheter is kind of like eking out of its insertion site. That's telling you that that catheter is moving out of the vein and could possibly migrate into another vessel. So that would be necessary to call the doctor. Please do not try to push it back in. Management, you want to prepare for fluoroscopy to verify position. So chest x-ray, assist with removal and new CVAD placement for catheter migration. Infection, it's invasive, so there is a risk of infection. Maybe someone broke sterile technique. That's why it's important. I know it's awkward, but to call people out about it. If you notice that it's happening, and it's important to admit it if you're the one who did it, so people don't get unnecessary infections related to their treatment. Let's see. We know what infection looks like, right? So if it's local, there's redness, tenderness, purulent drainage, warmth, edema. That's part of that inflammatory process. That would be like a local infection. Systemic infections, they may experience fever, chills, or malaise. And we'll talk a lot more about systemic infection for test 3. So go over the management of that. They would need to culture it. You would apply a warm, moist compress. So for infection, that's a warm, moist compress to enhance the body's vasodilation, bring more white blood cells to the area, and then remove the catheter if necessary, which would require a doctor's order. Systemic, they would need to take blood cultures, and with blood cultures, you need to take blood cultures from 2 separate sites to ensure that one of them is not contaminated. Antibiotics, obviously, to treat it, and then antipyretics to treat the fever, and then again, remove the catheter if necessary. Another complication is catheter occlusion. So the catheter gets clamped or kinked. The tip might be resting against the wall of the vessel, and then thrombosis would occur because if that is irritating the wall, remember clotting is part of that inflammatory process. Or there could be some sort of precipitate built up in the lumen. If you're giving special types of drugs, those may precipitate depending on the temperature of the body or the temperature of the solution itself. Manifestations of catheter occlusion include sluggish infusion or aspiration, the inability to infuse or aspirate. Don't force it though, please. Have the patient change position, raise their arm and cough, and then try again, but don't do anything forceful. Assess and alleviate any clamping or kinking. And then here, like I said, flush with normal saline using a 10 cc syringe, 10 ml syringe. We don't use anything less than that because the pressure is too high inside that syringe. And don't force the flush. If you can't get it unclogged, and when I mentioned the push-pause method, usually with like a PICC line, you got your catheter here, that's something invasive in the body. So what will happen is there may be some sort of like fibrin sheath that's on it that's like accumulating clotting things. Well, if you infuse saline and you push and you pause and you push and you pause, that creates this sort of like jostling off of the fibrin sheath and prevents it from clotting and occluding the entire catheter. So that's a kind of a prophylactic way to avoid this from happening. If this does happen, it's necessary to instill an anticoagulant or thrombolytic agent. Embolism, part of the catheter could break off, so I'll write that down for you. There's another complication. We're still talking about complications. So embolism, there could be a dislodgement of a thrombus. If you're not doing that push-pause method, that could be a problem. Entry of air into circulation. So make sure there are no bubbles. If you don't, usually a pump will detect if there are bubbles, like infusing. You want to make sure with those 10 cc syringes that you're getting that air out before you flush. And you'll know what I'm talking about when you get to clinicals, if you haven't already seen that. But embolism is going to include manifestations such as chest pain, respiratory distress, hypotension, tachycardia. So with an embolism, if it's in the lungs, if they're showing signs of tachypnea, dyspnea, hypoxia, cyanosis, all that respiratory distress, you want to apply oxygen, so O2, and we want to clamp the catheter, and we want to place the patient on the left side with the head down. So you put your patient on the left side, and then you put them with the head down, so that it's like reverse Trendelenburg, I think it's called. That traps the air embolus in the right atrium, and then notify the provider. I would just call rapid response, but also do all of those other things too, because the more help, the better. Finally, and then we'll end here, pneumothorax is a complication of an insertion of a central venous access device. Perforation of the visceral pleura during insertion. So we know our lungs have the pulmonary space, but they also have these layers surrounding the lungs called the pleural space. And if that's punctured, because we know the heart's, right in that mediastinum, and we have that SVC. If we somehow puncture this pleural space that air could enter and cause a pneumothorax. We have to have negative pressure in the pleural space to keep these lungs open, otherwise they collapse. So manifestations would be decreased or absent breath sounds on the side of the pneumothorax, respiratory distress, cyanosis, dyspnea, tachypnea, chest pain, and distended unilateral chest. So that one side of the chest is going to distend in response to that lung possibly collapsing. You want to apply oxygen and then place the patient in the semi-Fowler's position for a pneumothorax and prepare for chest tube insertion. That happens often at the bedside. One thing I want to recommend you guys go over is CVAD removal. So it's different according to agency policy. When I was at Baycare, they had us tilt the patient down while we were doing it. But what you want to do is have the patient bear down, like the Valsalva maneuver, for at least 5 to 10 centimeters of the catheter as you withdraw it, and then immediately apply pressure to the site with sterile gauze to prevent air from entering that vein, because you don't want an air embolism, and you also want to control the bleeding. So once you pulled that catheter out, make sure you look at it and determine that it's intact, and then after the bleeding has stopped, you can apply an antiseptic ointment and sterile dressing to the site. All right, that was a lot, but thanks for listening. I hope it helps, and I wish you the best of luck on your exam. And this is Megan Bailey. I'll give you my email address again real quick. bailey.megan@spcollege.edu. Thanks so much.